Good afternoon, everyone. We're going to start the next section where you will have complex cases being presented and the lessons learned, and we'll have one talk in between. For the first one, I invite Dr. Gerald Werner. He's going to talk to us on retrograde cases which he failed and what one has to learn from his failed case, which is going to tell us. Dr. Werner, please.
Okay, thank you. Of course, most of them are hungry, but for those who had already, maybe it's only one case, because I have so many slides. I will stop maybe after the first case, if it takes too long. But first a remark. I never heard the word failure in US and UK meetings recently, because they never fail. They call it now investment procedures, meaning you failed but can go on again and again and again after modifying the lesion. And so we should be aware that, of course, there are failures because the patient is not happy. The artery is not open. But we learn from these failures, and best is, however, to learn from failures from other people and not do the failures yourself. So I show you one of my real failures. But there are also failures where we cannot continue, and these are severe calcific lesions, and then we must be also responsible enough to find good coronary surgeons for your patients. Sometimes coronary surgery is an option. So this is one case, a young patient born 1960. I did it this year. Previous non-STEMI in several years. His history started 2004. Then he was sent to surgery, actually. And then all grafts are occluded. That's not very infrequent. PCI of the LED then happened in 2013 and an outside attempt for an LCX occlusion. You see that it is a dominant left system. And you see the circ coming here after some time via septal connections. So this was the situation in March this year. And there is a very tiny right coronary that does not provide any collaterals to the left system. So here, the other view, you see a tight lesion in the marginal, and you imagine that the occlusion cap must be here somewhere, because here comes the distal filling, but you cannot really see any stump. Here is the still frame. So here, probably by anatomy, must be the cap, but you can't see it. So the only option is, probably in this case, to go retrograde. And there is a problem zone, of course, the long occlusion. Then you have another tight lesion and some lesion proximal here. And then you have some collateral supply from the LED. However, the LED was stented, so some of these collaterals come outside through the stent. So my first setup was going transradial. That's the usual attempt. And a slender sheath, 6 French outer diameter, 7 French sheath. EBU 375. I wanted to secure the PL branch. The patient was attempted outside already, and they left the PL branch, which I thought was a good idea, because if you put a stent there, you make the retrograde access more difficult. And then start with retrograde to define the entry point, and then try antegrade, get into this cap. And if necessary, use IVUS. However, the problem was that I thought I can do this with one guide from the radial approach. Specific question here is, should you treat the marginal first? But then you would have to put a stent, and the stent might cover the proximal cap. On the other hand, this could make things a bit more stable. So I left it to it, first of all, and tried my retrograde approach. Here you see injection into one of the collaterals. Actually, it's a Carvel. I prefer Carvel for septal approach. in most of my cases, and you see the run-through in the marginal branch. Here you see the Sion wire, and what you see is the patient breathes heavily. That is an indication that this patient started to get very, very upset, even though we didn't yet start and there was no reason for angina. So we crossed into the collateral. It was through the stent, but I couldn't follow with the Corsair fully, so I had to dilate the entrance into the collateral with the Tasuna, and then the caravel could follow. So now I have the caravel through, and the wire already went very far up. I changed to an ultimate, and this passes almost 1 centimeter off outside of the occlusion. This is the other view. So here it's very close. And then I thought, I'm so close, let's go a little bit further without any IVUS. And it advances, but you can see it is outside of the lesion and of the vessel. So this was a bad decision because this creates a dissection and you cannot undo the dissection. So I had to do IVUS, and IVUS reveals severe dissection. I didn't bring the IVUS image, but you see also by injection here that this was a very bad decision to go into the proximal area without really safeguard of the IVUS. So now another patient problem came up. He became very uncooperative, severely restless, no angina, but it was just psychological. So we needed deep sedation, and it was very difficult to keep the radial access because the patient was really physically getting very active until the propofol kicked in. Further on, the retrograde wire manipulation was impaired. I tried to switch to a Corsair. It didn't help. A fine cross, but the fine cross could be advanced, but manipulation was better. So how do we get out of this situation? I try now to get into the proximal cap from antegrade with various wires, Confianza Pro, Gaia, Miracle 12, to do a modified reverse card, and from retrograde with strong wires. But basically I failed. Here you see the best situation. I have a balloon there, and that would be the modified reverse card. You balloon outside of the lesion and try to get into the balloon occluded or inflated side from retrograde, but it didn't work. And we see in the IVUS a severe dissection, so basically impaired flow, and on IVUS the proximal circ looked severe, so I had the problem that the dissection extends all the way into the left main. So what I had to do is put stents there, and you see it didn't even look very nice on the angio here. Let me see. I want to show it. It doesn't look too nice, but on IVUS I had contained the dissection, and of course the distal vessel was open. It was severely spasmic, but no problem there. So what to do? Patient went home. CABG is no option for this patient, so we scheduled another procedure. But you need to take some message from the first failure. So what can we improve? And of course now I have created the proximal cap covered with a stent. Maybe I ask the chair, what can we do different? What should we do different in a second attempt?
My question is that in the first attempt, could you use a MAC catheter for the entry into the via the retro antegrade? You had taken a MAX mother and child or any other of those heart rail catheter and entered the retrograde wire into this catheter, avoiding dissection of the left main in the first. Was it possible to do that in most of the cases of left system?
You mean to take a guideliner antegrade?
Antegrade and get the wire into that.
With the same catheter?
Yeah, with the same catheter, get the wire into it, using a mother and child instead of
You
getting
could do that with 8 French, yes. But one other option, so this is the situation 7 weeks later, just to tell you that, of course, the distal vessel has recovered and the artery looks quite good. So the situation is almost the same. And the patient is symptomatic. But what we did, and distal anatomy here, you see the shots. What we did, this is an option. We have now mother and child, 5 French from Gideon, IMDS, a European company. The Gideon, you have it in 5 French. So you could put it into a catheter separate to another device. But here we started with deep sedation right away, bifemoral access because the radial didn't work the first time, and I used 2 access now. For the retrograde, a separate access, and for the antegrade, a separate access, so the ping-pong technique. And right away start with IVUS in the antegrade approach. But of course, again, we need to go retrograde. We choose another collateral because the first collateral didn't show up. Similar, so this is again a caravel. Then this caravel followed by a Sion. I will show only one case, so I won't take too long. Just to show the real-life passage. There's some tortuosity, which we realized. And here we go. Could advance the Sion very easily, and the Sion and the caravel, and the Sion was close to the stented segment. And now we bring, of course, a wire into the marginal branch, and then bring the IVUS. And for penetration into the stent, you need actually a very stiff wire. So I started actually with a Confianza Pro 12. One thing that you have to make sure is that the stent is maximally expanded, because you don't want to leave space behind the struts where the retrograde wire could end up. It's most cases it's easier to go antegrade through the stent struts towards the distal wire, but in this case it didn't work. So I couldn't actually enter because of the angle. So the Confianza Pro didn't work, so I take the Gaia 3 and realize on IVUS that it immediately slips into the stent struts, into the center. And this time, of course, we are protected from proximal dissection and could get into the proximal guide. We advance the caravel easily through the stent struts. The caravel is now proximal, and of course I exchange for a soft wire to engage into the AL. I took a AL, a different configuration for the antegrade approach. You just work on the guiding catheter to put it in position, and now it slipped in, the Sion slipped in. You inflate the balloon, you externalize, and I kind of did a delayed culotte technique here for the stenting of the distal circ. And this is the final result. So, what did I learn? It was in the single guide approach. In the first attempt, it was very difficult to manipulate the wires because of the cramped space. A double guide would have been the right choice right in the beginning, and it should be always preferred in long CTOs of this kind. I think IVUS was used too late in the first approach. The first wire manipulation had already damaged the proximal circ, and I shouldn't have started without IVUS in place. And of course, sometimes you need a bit luck for the second attempt. It was a lucky strike that I got the Gaia 3 easily through the stent struts. So I learned something from this. I will most of the time go with the ping pong technique in these long ipsilateral lesions always. So thank you very much.
You used the word modified cart.
Yeah.
So there is now modified cart, there is contemporary cart, there is a
Conventional.
classical conventional cart.
Yes.
Yeah, that is what.
The modified cart, which I learned just last week in the CTO club in Nagoya, because I also thought modified and contemporary should be the same, but it is not the same in the Japanese mind. Contemporary is working with a small balloon and getting with the Gaia towards this retrograde Gaia on this antigrade balloon. And the modified cart is when you go beyond the lesion and inflate the balloon proximal to the lesion because of some situations where you cannot get the balloon inside the CTO body. So that is the modified cart.
Dr. Vanna, my question to you, how is the patient's symptomatic status now? Because he was quite symptomatic, as you said, after he left your place. I mean, like you have got now a bifurcation kind of stent, inviting more restenosis and more problems. In the down distal vessel you see, which was collateralized well, was not a very large vessel. So in clinical context, do you feel that stenting, doing a bifurcation stent in this situation or second attempt was quite justified?
You think it was not a large vessel?
Well, the distal IC is quite diffuse and not a very large.
Because I expanded the stent very much, it was still a very slow flow off or impaired distal diameter. But this is a huge territory for the patient. We had an initial ischemia test of 15% ischemia, and the patient, believe me or not, was immediately symptom-free the next day when he awoke from his propofol. Yeah? So he had continuous angina for more than 2 years, and after this, he was angina-free. So it's a big territory, the dominant circ.
So our indication was basically the angina symptom persisting and documentation of ischemia.
Yeah.
If probably that was not there, would you have left it alone or still made a second attempt?
It's very difficult to the acoustic here is...
No, my question to you, if the patient was asymptomatic, and would you like to make a second attempt once you have had a problem for the first time?
I wouldn't treat an asymptomatic patient if he wouldn't have an ischemia test. If I fail in this asymptomatic patient with an ischemia test, I will still go on with a second attempt because the indication is the same.
Thank you. Ganesh. Thank you so much.
It's very difficult.
The second speaker for today's presentation is Dr. Ganesh Kumar. He's going to talk to us on re-entry into true lumen. Dr. Ganesh Kumar, please.
Okay. This topic I chose, it's a slides made a few years back, but what specifically I want to do is I want to summarize everything since yesterday we have been speaking, Prakash Veer spoke on how to stay intralumen, I mean how to stay within the lumen. It was like 10 commandments, he spoke beautifully. Then in the morning we saw the parallel wire session and how Dr. Sumit Suji also spoke about, this is his model actually. He spoke about how to be from intima to intima. So it is like a small summary that I made, what I would do when we go outside the intima and how to re-enter. So what's the, you can say, protocol, or what do I follow? So I'm not going to elaborate the techniques too much, but just what we do. So this is a preferred thing, and this is what we don't want. So what are the various options? That's what I'm going to talk in next 10 to 12 minutes. Parallel wire technique we have been hearing since yesterday. In the morning, Dr. P.K. Goel spoke in detail for 15 minutes. So I'm not going to talk too much. IVAS guidance and dissection re-entry techniques. So my concentration will be more on dissection re-entry techniques. In the dissection re-entry techniques, dissection cross-pass, we all know that it's a new technology which is now getting available in India. But re-entry techniques, some of you may not have heard about the last technique or the contrast-guided star technique. So let me touch upon some of these terminologies which you may not have heard. A parallel wire technique, as you told, when a softer wire fails to go because it goes into the subintima, the second wire you need to take, which is probably a little more stiffer, and redirect away from the intima and get into the true to true. One such case of parallel wire, I think this is a case which gone into the subintima and then could go into the, with the second wire, we could go into the true lumen and exchange it for a we don't inject anymore nowadays with the microcatheter. This is a case which I did almost 7 years back. We injected, confirmed that we are into the true lumen and changed the softer wire and do the case. IVAS guided. This is one thing which we want to do it, and our experience amongst many of our colleagues is not much. Dr. Sumit Suji showed in the morning a beautiful presentation how to understand the histology first and then use an IVAS guidance and correlate with the angiographic views to enter into the true lumen. The basic that I follow is I use the color Doppler in it, that is chromo unit, so mine is generally the volcano system. Sometimes the IVAS can be challenging because it might increase the size of the subintimal space, especially the previous generation IVAS catheters, and at rarely it can also give you perforations, which if you push too hard with your IVAS. Sometimes to accommodate an IVAS, you also use a small balloon, so it is an issue, but putting it in the side branch, it's much easier. One such case where the lesion is just below the diagonal, put the IVAS in the side branch and trying to wire it, and then you see the wire is at 1 o'clock position. The color Doppler is the central lumen, where on your left side, rather for you on your left side is the IVAS in the diagonal. On the right side, you could see, again, let the loop run, you could see that in the center that is the actual lumen, and my wire had actually gone subintimal. So since it had gone subintimal, I had put the IVAS in the diagonal. See that wire, it is outside the, this is the wire. The wire will be here at this portion. So keeping the IVAS there, rework on it, pull back the wire and go into the true lumen. So got it into the true lumen. So this is one of the ways of using the IVAS technology. This is another case. After opening the vessel, you see that the wire, without the IVAS, we would have got a no flow, because actually the wire is in the false lumen. The thin, this particular thing is the true lumen on the top. This is the true lumen. So when you do an IVAS in such a situation, this is the actual true lumen, and this is the false lumen. So had I ballooned it, I would have closed this distal RTA. So keeping the IVUS there, this is a small slit you see between 1 o'clock and 5 o'clock. That slit is the actual true lumen. The actual wire is in the false lumen. You see the slit from 1 o'clock to 4 o'clock? That is the true lumen. So keep the IVUS there and then wire it into the true lumen and then stent it. And then you see a small dissection which extends into one of the small branches of the PD. So that was actually the false lumen. So IVUS does help in coming back to the true lumen from a false lumen. Star technique, it used to be one of my favorite techniques in the past, especially when you have no other option. So I have used on almost all occasions a fielder FC wire, make like an umbrella shape J at the end of the wire, take it over a microcatheter. You are already in the subintimal space, and then you have no control how to exit. So I will show an example and tell you how we do this particular technique. So this is the case which I had done in a live case in NIC in 2011, I think, at Calicut, 2011 or 2012, where I was trying to do a mid-RCA CTO, and my Miracle 12 had gone into the subintimal space and couldn't do with the parallel wire also. So you see my microcatheter is in the part of the tip of the microcatheter is in the false lumen, and then I change my wire and take a fielder FC wire and try to follow this this picture. So when you rapidly exit, it has to be rapid movement. When you rapidly exit, it will go from a true lumen to a false lumen to a true lumen. My microcatheter proximal part is in the true lumen. The tip of my microcatheter is in the false lumen. So my wire is exiting out from the intima, and then it cuts through and enters into the true lumen. So where does it cut through? Wherever you have a bend, it will cut through. So here, if you see, the bend of the RCA is here. Okay, so at this portion where it is going to bend between the junction of the mid RCA and the distal RCA, it will cut through and enter into the true lumen. Okay, or at times if you are unlucky, it will continue traveling through the false, and at the PDPLV junction, one of the artery it will catch and enter into the true lumen. Okay, so it is quite a, you get a good success in, especially in right coronary arteries and obtuse marginal arteries. In LAD, you generally don't get a good result with a star technique. So that is the concept of a star technique. I think even Dr. Duggal used to use a lot. I have seen him doing even in my lab in 2009-10 a few times when we are done. I spoke about this. The high success rate is in the right coronary artery and the OM. Now, I have not used this technique, but it has been described by Carlino. Since I am talking about various methods, so I will touch briefly. Instead of using a wire, Dr. Carlino uses a microcatheter. He injects with a force with a 1 cc syringe contrast, and while he's injecting, he rapidly advances the microcatheter. So again, from a true to a false to a true, it exits out. So you can say it's a modified type of a star technique. Instead of using a wire, he uses a microcatheter. I have not used this particular technique. There is a technique called as limited antegrade subintimal tracking, also called as last technique, where once the microcatheter, it is like you start like a star technique. More so it is useful in LAD, because if you rapidly continue going into the LAD, you will continue going into the false, and up to the apex of the LAD, you can continue to be in the false passage. So you are stuck and you will have an unsuccessful case. So what you do is you make a knuckle like I showed in the right coronary artery, cut through the false lumen a little bit, and then I will show an example. Then this is not my case. This has been taken from CCI, but I will show my case. So this is basically an LAD. I have formed a loop and I cut through and I enter to some extent I have entered. And once I enter into it, I advance my microcatheter, I remove my Fielder FC wire, and then I will take one of the Conquest Pro wires, shape it and try to cut into it and enter into the true lumen. So what is this concept? The concept is I have got away from the CTO, I have come below the CTO, but I continue to be in the false passage, but I am below the CTO. So when I am below the CTO, I can redirect my wire and come into the true lumen. This is the exact concept where the Stingray concept has come. So the Stingray is like you go beyond the CTO into the subintima, and then you take a wire and penetrate and come into the true lumen. So you can say it is like a limited star technique. In LED, generally when you use a star technique, you can cut through into the true false lumen till the apex, so it's not recommended. Crossboss, all of you know, Nimit is going to talk on it in the evening. I think Arun is going to talk from US. He's going to do a live telecast from US in the crossboss Stingray session, so I'm not going to tell you in detail, but basically it is a blunt catheter and you spin the catheter and you can enter from a true to a false to a true lumen. If you don't, then you stay there and take the crossboss. The crossboss is the catheter. If you don't, then you take the Stingray balloon and exit from one of the ports, which in a lot of detail, Arun and Sudhir Rathod and Nimit Shah are going to talk in the evening symposium and the Stingray crossboss. So I'm not going to tell you in detail, but the concept is similar to somewhat like a last. So my approach. Parallel wire technique, of course, all of us will keep it as a first approach, and we have to come out of our shyness from using IVUS. Believe me, you start using it, there is a learning curve, but after a particular time, you will start getting success by using IVUS. And we do have an imaging symposium in the evening, and you will see a lot more of it on IVUS. And then, of course, star technique is a preferred choice in right coronary artery and circumflex. Last is a technique when you are desperate in an LED, you can do some of these cases with last technique. And of course, crossboss and Stingray is getting available more and more in India. Thank you so much.
Thank you, Dr. Ganesh Kumar, for your nice presentation. We can take one or two questions if the audience have any. Are there any questions, please? So, no questions, so we move on to the next presentation. Next, it's clear your presentation very, very lucid and informative to the people here. The next presentation is by Dr. Rajpal. He's going to talk to us on LV function improvement in CTO PCI. Is it a reality or a myth? Dr. Rajpal, please.
Well, good afternoon, everybody. It is indeed a pleasure to be here. And let us look at, can I have the slides on, please? Yeah. So the topic for today's discussion is LV function improvement. Is it in CTO PCI? Is it myth or reality? So before we go into that, I mean, all of us should be aware of why we do CTO PCI. Obviously, it's for the following reasons: that relief of angina, improvement in the ischemic burden, improvement in left ventricular function, and the concept of double jeopardy, that is, a patient who has an occluded vessel will in future tolerate an occlusion of another vessel better. So this is the concept of double jeopardy. And then there is a concept of potential mortality benefit after successful recanalization, and also reduction in the need for bypass surgery. So first, let us look at what is the improvement. Is there any improvement in LV function after CTO PCI? Actually, this question, multiple studies have been looked at in an attempt to address this question. And the first significant data that we got was in 1994. And this journey begins from 1994 up to just as recent as a month ago when recent data has come out. And the answer to the question of will left ventricular function improve following CTO PCI, the answer has been over these few years, almost 18 years, has more than 2 decades, has been the answer has been yes, maybe, no, and then finally maybe, and we are right now stuck. I think the answer is somewhere in maybe. In these more than 2 decades, there has been only one randomized trial that addresses this issue. It's very difficult to get a randomized trial in this issue. And I think this whole issue raises more queries than answers. The first trial was in 1994. It was a retrospective, it's not a trial. The first study was a retrospective study of 49 patients who underwent successful CTO PCI. And all these patients had an LV angiogram before PCI and 2 to 2.5 months or 10 weeks after PCI. And the ejection fraction was assessed by a rather, in today's world, a rather crude method, but at that time it was significant, and it was the center line method on an LV angiogram in the RAO view. And they found that the global left ventricular function did improve, but the problem here was all these patients, it was an RAO view, so only the LAD and the RCA territories were looked at, and no circumflex CTO was assessed. So what did they see? That all patients who underwent a CTO PCI and the vessel was patent at the end of 2.5 months, that is 10 weeks, the ejection fraction increased from 52 to 55%, plus or minus 7 to 62%. And in those patients, if you look on the extreme right here, when the repeat study was done, and if the vessel was occluded, there was no increase in LV ejection fraction. So this again, it makes sense that those patients who had viable myocardium and the vessel remained patent, there was a good increase in ejection fraction. Now, even if the vessel restenosed, the increase in ejection fraction continued, the benefit continued to remain, even if there was even if the patient had a restenosis but no occlusion. So this goes to say, this from this study, that the first study which said that, okay, if you want to do a PCI in a CTO, you have to prove that there was viable myocardium, and it was best to make a strong attempt to keep the vessel open. So you have to make sure that you get aggressively and you had a good result. Now, in 2003, there was another study from Japan, and from Chung et al. Looked at 75 patients who again underwent PCI, successful CTO PCI, and had an LV angiogram at baseline, and this time up to 6 months a repeat LV angiogram was done. This was again a retrospective study, and there were 2 groups of patients. One who had a prior myocardial infarction, and the second group of patients who did not have a prior myocardial infarction. Group 1 was those patients who did not have a prior myocardial infarction. So again, if you look at this data here, those patients who had no prior myocardial infarction, the LV ejection fraction improved significantly at the end of 6 months. But those patients who had a prior MI did not have a great improvement in ejection fraction. So this was the first study which showed this, and therefore it was very clear that you had to prove viable myocardium before you had to do a CTO PCI. Then those people who did not, in group 2, those patients who had a prior myocardial infarction, if they too had an increase in ejection fraction if these patients had good collaterals and the vessel remained patent at the end of 6 months. So this is important. So these patients, you had to show that even if the patient had myocardial infarction, if the patient had good collaterals and the vessel remained open at the end of 6 months, there was benefit. This is again a surrogate of good viable myocardium. Then it took 10 years for enough studies, or almost not 10 years, 17 years for enough studies to accumulate and for a meta-analysis to be done. The first meta-analysis was on 13,000 patients, but they did not look at LV function, so we let this pass. There was another study of 40 patients with tissue Doppler imaging, which showed that again there was a significant increase in LV function. This was in May 2014. Now, let us come to this meta-analysis. So it took almost 2 decades for enough studies to be done and a meta-analysis to be done to look at successful PCI, CTO PCI, whether it improves LV function. So this was 2,000 patients and who had successful PCI, and LV function data was analyzed, and they showed that there was an improvement in LV function by 4.4% and an increase in LV end diastolic volume by around 6 ml per meter squared. So this was the first meta-analysis after 2 decades of CTO PCI. So from what you must have gathered is that it's very difficult to have CTO PCI data, and because numbers are small, and up to this point there was no randomized trial which looked at this issue. Then there's no direct comparison between optimal medical treatment and CTO PCI. There is no such data. So till we come to the next study. Then outcome comparisons exist between successful PCI and failed PCI, LV function, mortality in successful PCI. But this is an unfair comparison because failed PCI patients may have a greater disease burden. These patients would have much more complex disease, and these patients would have been preferably shunted to bypass surgery. So you can never make a real comparison in this setting. So what then came out was there were 3 randomized trials and which looked at issues in CTO PCI. The 3 randomized trials were the Explore trial, Decision CTO, and the Euro CTO trial. Out of these 2 one is ongoing, the Euro CTO trial, we still do not have the data, but the Explore trial and Decision CTO trial, we have data. Out of this, only 1 trial addressed LV function. That is the Explore trial. Before we go to that, just a brief word about the Decision CTO trial. This was a Korean trial. They looked at 850 patients. All patients had optimal medical therapy. Like even these patients could have multi-vessel disease, double vessel disease, triple vessel disease, but all these PCI was done in both arms. Both arms of the trial underwent PCI. But these, if there were 3, suppose a patient had triple vessel disease, then the non-occlusive, non-CTO PCI was done, say LAD proximal 90, RCA proximal 90, angioplasty was done. But if they had an OM or an LAD CTO, that was left alone. The CTO lesion was left alone. Other lesions underwent angioplasty. So PCI was done for the non-CTO lesions, and the CTO lesion was what was followed up medically. It was a negative trial. All the major adverse cardiac events, the primary endpoint, and all individual endpoints, there was no difference at the end of this trial, but this trial did not look at LV function. So now let us look at the Explore trial, which is the single trial. the only trial as of date which looks at LV function in patients with a CTO. So they looked at 304 patients who had acute STEMI and a concurrent CTO. So in a STEMI setting, the patient underwent a primary PCI, and the other vessel, which was a CTO, it was this patient had a STEMI and a concurrent CTO, and early PCI was done for 150 patients, where they were randomized to quick PCI for the CTO within 4 to 5 days, and medical follow-up for that PCI within 4 to 5 days. And the primary outcome was LV ejection fraction, LV end diastolic volume on cardiac MRI. This was a very good trial because you had cardiac MRI, which is quite accurate, and at the end of 4 months. And why did they choose 4 months? Because they believed that 2 to 3 months is more than enough for any of the hibernating myocardium to recover LV function. So at the end of 4 months, what did we see? And they took 4 months because this was enough time to look for a change in LV function. Any hibernating myocardium would by this time have recovered contractile function if it was going to contract. But this trial was too short to look at mortality. 4 months is nothing. It was too short to look for the advantages of double jeopardy in the fact that, if another vessel occluded, what would happen? But it was enough time to look for change in ventricular function. This was again a negative trial and did not show any improvement in LV function by all parameters, and LV end systolic volume by cardiac MR, LV ejection fraction by cardiac MR. Overall, it did not show a benefit. But there was one location, one subset of patients, if the CTO was located in the LAD territory, which is again, one would take it as a surrogate for a large myocardium at burden, large ischemic burden. It showed that there was a significant improvement in LV function of about 7%, but this was only in those patients who had an LAD CTO PCI. So, in conclusion, LV function may improve after PCI, but what we should be sure is make sure that the myocardium is viable. There's no MI in the CTO territory. Even if there's an MI, they make sure there's viability. And if this patient has good collaterals, had good collaterals prior to CTO PCI, the chances of improvement were greater. And also this fact reiterates the fact that if you do a CTO PCI, please do not accept a suboptimal result, because if this vessel closes somewhere down the line, then all the benefit of the CTO PCI is gone. And LAD CTO PCI is the only vessel which has evidence to say that there is improved ventricular function. And also it's important to keep in mind that before you do a CTO PCI, to have an ischemic burden of at least 12, more than 10%, actually the cutoff value is 12.5%. So if you have an ischemic burden of 12.5%, then we are justified in doing a CTO PCI, because below 12.5%, an ischemic burden of 12.5% on nuclear imaging, there is no clear benefit of doing a CTO PCI. So this is something which we should keep in mind. So to conclude, I think that we need to go a long way. We need to go some more to clearly define and make sure that there is a ventricular function benefit, which then again translates into mortality benefit but we hope to reach there. And in today's, truly world wherein we are questioned in so many ways, the media, the print, colleagues, other departments. So we need to be sure that you really prove viable myocardium. That's very important before you embark on a CTO case, on that case. And second thing is, be sure that you have an ischemic burden of more than 12.5%. This is a very key number. Below 12.5%, there was no benefit in any parameter. You have to have an ischemic burden of 12.5%, and it's best to talk to the patient, make sure that he understands all this before you take on the case. So I thank you for patient listening.
Any questions? Because this is a very interesting, because we always say that the LV function improves. And these two new trial decisions, CTO and Euros, has shown not much benefit. So this is a very important thing. And any question on this?
Actually, the EXPLORE trial did show some benefit in a subset of patients where the LAD was the occluded vessel.
Dr. Rajpal, very rightly said by you that you need to document ischemic burden before you really attempt CTO. In clinical terms, there are some criteria probably laid down, which probably our audience would want to know before you really attempt on CTO, how you go around looking at them.
No, I think the first issue is this patient symptomatic? And the patient is clearly symptomatic, one. Second thing is, you have to absolutely make sure that you have crossed the ischemic burden threshold. So you have to make sure that you have to have suppose there's a, say, prox LAD occlusion, there's no need to look for ischemic burden because it is a large territory. I'm talking about when there is a doubtful ischemic burden, say an obtuse marginal or a mid-distal right coronary artery, you have to make sure that you have an ischemic burden of 12.5%, and this is done by nuclear imaging. When you do a nuclear imaging study, they'll give us the ischemic burden. So you have to make sure of that. Viability, ischemic burden, and you must have a complication rate of less than 1%. And then if something goes wrong, we still are on a firm footing to say that we did the right thing, and if things went well, it's fine. And if things do not go well, we still are on a firm footing. If we show viability, ischemic burden of more than 12.5%, a complication rate of less than, it's actually 1.4%, then we have a moral ground to say that we did the right thing. And the second thing is, we must be sure to say that when we did the procedure, that the patient was adequately informed of all the options before we actually did this case.
Thank you, Dr. Rajpal. Just to add to this, one or two more things have been described. I don't know how much they are relevant really here. Is the echo findings. You know that the echo is important to look at the LV size and the LV function before you really attempt one. And if the area is not thin scarred, obviously the viability will not be there in that thin scarred area. And if you have a CTO, let's say in an LAD territory, and on the ECG you do not find any infarct pattern, you find preserved R-waves, with the echo showing a good, reasonable size left ventricle, that is another area where you can really think about opening the CTO.
Sure. So that's all markers of viability, functioning myocardium.
Thank you, Dr. Rajpal.
Thank you so much.
Now I would request Dr. Hamazaki to my worst complications and how I managed it.
Thank you, Chairman. I would like to talk about my case. And this case is a live demonstration case at IJCTO last year at the Haramandari Hospital. So, the case is a 55 years old female, and the target region is a CTO at proximal LCX, and her diagnosis is angina and prior intervention. And she received PCI for this region twice, 2013 and 2015, but failed. So I have to perform a PCI last year. Ejection fraction and renal function is normal, and her coronary risk factor is dyslipidemia and diabetes and hypertension. Target region was CTO at the proximal LCX. And the distal part of CTO was not clear, although dual injection was used. Collateral flow from RCA and LCA exist. This PCI was the third attempt for this region. Therefore, retrograde approach is better if possible, of course. At first, retrograde channel was checked persistently. However, good collateral from RCA could not be found. Diagonal branch gave collateral flow to distal part of CTO. So chip injection was used to find collateral channels. Chip injection was performed again. And the chip injection was performed again and again. Of course, I want to use a retrograde approach if possible. However, interventional collateral channels could not be found. So, PCI start with antegrade approach. IBUS guided wiring was planned as the primary strategy because distal condition is very bad to perform other strategies. It was not easy to advance guide wire into CTO in this time, so complex flow was necessary to advance guide wire into CTO. I was performed to confirm guide wire position. I was showed the ideal route was 2 o'clock on the IBUS image. This is the ideal route. As you can see, this is an intimal plug. IBUS guide wiring with Conquest Pro was performed just like this. Conquest Pro could be advanced. IBUS showed guide wire be advanced into the plug. You can see this is a plug, and the Conquest Pro is in plug. So Conquest Pro was advanced more distally. However, Conquest Pro was advanced, but the movement of guide wire became too big, as you can see. It was thought that guide wire was advanced outside vessel. Yeah, guide wire movement is very big. IBUS was performed to confirm guide wire position at only proximal part. Of course, distal part is, I'm not sure where is the distal part. So I check the only proximal part. IBUS showed guide wire was in the plug at the proximal part. Yeah, proximal part is a good position. This is a space made by previous guide wire. Okay, now guide wire position is not so bad. So IBUS was advanced more deeply. IBUS showed guide wire was subintimal lumen at the distal part. True lumen is here. So IBUS guided wiring with Conquest Pro was performed again. Conquest Pro could be advanced, as you can see. IBUS showed guide wire was advanced into the plug. You can see, yeah, this is the plug, and the guide wire is here. The position of second guide wire looks better than first guide wire. Therefore, a second guide wire was left, and the first guide wire and IBUS was removed at that timing. After IBUS and first guide wire was removed, blood pressure was down. UCG performed, and UCG showed a pericardial effusion. So, pericardial synthesis and drainage were performed. And then PCI could be continued under drainage. Of course, my next step was IBUS. In this timing, IBUS had two roles. One is to conform guide wire position. The other was to stop bleeding. IBUS guided wiring was performed again. IBUS showed true lumen was 9 o'clock, and the second guide wire could be advanced in the plug, as you can see. True lumen is here, and the second guide wire is in lumen. So, from this IBUS findings, connection between true lumen and proximal lumen was already created. So, in this timing, exchange of guide wire from CTO wire into Sion black was performed. Finally, as you can see, Sion black was advanced into distal true lumen. As you can see, very smooth. IBUS showed a guide wire pass through true lumen from proximal to distal side, all true lumen tracking. CAG after stenting showed good recanalization without leakage. Stenting in the true lumen could seal perforation completely because perforation occurred in subintimal lumen. So, stenting could seal performed completely by intimal plug. Any additional treatment was not required. Her post-operative progress was going well. Drainage was removed the next day, and she could discharge 3 days after PCI. As you know, IBUS guide rewiring is the final strategy in current strategy for CTO PCI. So, this is a summary of my presentation. This is the third attempt for CTO PCI at LCX was performed. Retrograde channel was checked first. Of course, this is the third attempt, but interventional collateral channel could not be found. So, PCI started with planned IBUS guided wiring. Guide wire was advanced outside vessel once, and cardiac tamponade occurred. Therefore, cardiocentesis was performed and PCI could be continued under drainage. IBUS was useful for not only guidance for wiring, but also hemostasis in this case. Finally, guide wire could pass CTO through true lumen completely by repeated IBUS guided wiring. Not only dilatation of CTO, but also hemostasis could be achieved by stenting because guide wire pass through lumen completely. This is my take-home message. Never give up, even if not only parallel wire technique, but also retrograde approach fail. IBUS guided rewiring can provide procedural success to us. Finally, success of this PCI thanks to Dr. Kumar, because he never said to me, stop procedure, Dr. Hamazaki. Thank you for your attention.
So this was a very good case, how it was managed. And the perforation was discovered just by the wire movement it was discovered. And subsequently, the patient went into his BP and hemodynamics change. And it was very well managed. And the procedure was continued despite having a perforation. That was the important thing. So any question? Otherwise, we conclude this session. So thank you very much, Dr. Yam. We conclude this session.